এই যে হার্ট জিনিসটা, এটাকে বলা হয় এটা ইজ লাইক এ মেলিগনেন্ট কন্ডিশন। কেন? একটা হার্ট ফেলিওর পেশেন্টের 5 ইয়ার সার্ভাইভাল 50%-এর কম। অনেক ক্যান্সারই, আমি যদি ব্রেস্ট ক্যান্সার করি, 5 ইয়ার সার্ভাইভাল, মর্টালিটি রেট অ্যারাউন্ড 10-20%। কোলন ক্যান্সারের সার্ভাইভাল প্রায় 60% মতো, মর্টালিটি রেট 30%। লিকিউমিয়া, যদি সবকটা লিকিউমিয়া ধরি, তার মর্টালিটি রেট 5 ইয়ার মর্টালিটি 50% আছে। তার মানে হার্ট ফেলিয়ার এতই মেলিগন্যান্ট কিন্তু আমাদেরকে না, কিন্তু যে কোনো ক্যান্সারের সমতুল্য এটা মৃত্যু হার। এটাকে ওই পরিমাণ ইম্পর্টেন্স দিয়ে আমাদের ট্রিটমেন্ট করতে হবে, বিশেষ করে এই কোভিড-19 সিচুয়েশন। আজকে যিনি কথা বলবেন প্রফেসর খালেকুজ্জামান, আমার সহকর্মী ঢাকা মেডিকেলে, আমার অনুজ সমতুল্য, একজন স্থিতধী, প্রজ্ঞাবান, খুব সংযত এবং খুব সংহত একজন কার্ডিওলজিস্ট। সে, তাকে দেখে বোঝা যায় না, কিন্তু আমি তাকে বলি সলিড কোর। মানুষটি হলো সেরকম, যেমন তার জ্ঞানে তেমনি তার আচরণ। আজকে আশা করি হার্ট ফেলিওর নিয়ে যখন প্রফেসর খালেকুজ্জামান কথা বলবেন, তোমাদের সবার ভালো লাগবে। Let us enjoy together the lecture from Dr. Mohammed Khalequzzaman, COVID-19 and heart failure. Let us enjoy his talk.
I am Dr. Mohammed Khalequzzaman. I will try to discuss on a case which developed heart failure in the background of COVID-19 pneumonia. And the treatment in the background of COVID-19 pneumonia, you see, they is a bit cumbersome and difficult. You have to treat both the conditions and its underlying etiology. So let us begin with our case scenario, what is happening. And we see the COVID-19 now is spreading across the border zone of the India, in the Bangladesh, notably in the Rajshahi, Chapainawganj, and so on other areas near the border area. Our patient, a 55 years female from Rajshahi, has been transferred to DMCH with 8 days of the symptoms with cough, shortness of breath, fever, with progressive deterioration of the general health. She was diagnosed as a case of COVID pneumonia 6 days back, and initially she was treated at home with antipyretics, antihistamine. With this treatment, she was improving. She is not diabetic, but she is hypertensive. And you know, there's some females are smokers. She was also a smoker. For the last 2 days, she developed high fever with increasing shortness of the breath. On examination, she was febrile. Heart rate was 120 beats per minute. Blood pressure was 180 by 90 millimeter of mercury. And the oxygen saturation fall up to 91% at room air. And on examination of the lungs, chest reveals that she has bilateral diffuse crepitation extending from base to apex of the lung ribs. Examination of the precordium reveals that she has a normal heart sound, S1, S2 are audible, with an added sound of heart, S3, and at the same time, there is a gallop rhythm. So what is the possibilities in this case? We know the patient is COVID-19 positive. She is hypertensive. She is a smoker. She has COVID-19 pneumonia. Subsequently, the clinical features beginning from lungs to precordium reveals the features of the heart failure in the form of acute left ventricular failure. So what should be the possibilities of our diagnosis, possible diagnosis in this particular case? Can anybody participate from the audience?
আপনারা একটু আনমিউট করে পার্টিসিপেট করেন, অথবা আপনারা চ্যাট বক্সেও কিন্তু লিখতে পারেন।
Very simple thing. You see the patient is hypertensive. So the one of the diagnosis is hypertension. And at the time of the presentation, she has 180 by 90 millimeter of mercury. Systolic 180 and the diastolic blood pressure was 80 millimeter of mercury. And she was a smoker.
যে কেউ একজন ভলান্টিয়ার হয়ে একটু রেসপন্স করেন প্লিজ। একজন লিখেছে মডারেট কোভিড নিউমোনিয়া উইথ হাইপারটেনশন উইথ অ্যাকিউট হার্ট ফেলিওর।
Excellent, very nice.
ডক্টর সারা লিখেছেন জি।
She has COVID-19 pneumonia, no doubt. If we label it mild, moderate, severe, critical, then we have to label it as moderate. So if she has answered very nicely and very correctly, and she has also uttered the diagnosis of acute heart failure. So excellent. Is anybody differ about the diagnosis, or anybody want to add more with the diagnosis? So let us proceed. What comes? So she's correct. The COVID-19 pneumonia, moderate type, with features of the heart failure, possibly from COVID-induced myocarditis, and at the same time the patient is hypertensive. So complete diagnosis should be COVID-19 pneumonia, moderate, with systemic hypertension, with heart failure from myocarditis. That is one possibility. Second possibility is COVID-19 pneumonia, moderate, with systemic hypertension, with acute coronary syndrome with heart failure. And third, septicemia. Fourth, acute pulmonary embolism. And fifth one is cytokine storm syndrome that leads to multiple organ problems leading to heart failure. So let us see one by one which should be fitted mostly compatible with the history and the examination findings. So if we think about the myocarditis, I think you have already gone through the myocarditis in the COVID-19 pneumonia. Incidence of the myocarditis is thought to be around 20 to 20 per 100,000, and the true epidemiology exactly known. Raised troponin is often observed in myocarditis, but differentiation between the myocardial injury and the myocarditis may be challenging, because you see the myocardial injury may occur due to vascular cause, due to coronary problem as well. So sometimes it may be very difficult to differentiate between the two. In the absence of the cardiac magnetic CMRI or endomyocardial biopsy, a final diagnosis cannot be always made. Echo may help, but many a time it may produce confusion with acute coronary syndrome. In the absence of the myocardial ischemia, a significant troponin I rise may be indicative of acute myocarditis in the appropriate context. So in this particular patient, we did not get any history suggestive of acute coronary syndrome or any ischemic problem in the form of central chest pain, compressing type, squeezing type that may radiate towards the left side of the jaw as well as left upper limb. There is no history such type of ischemic chest pain. So in the absence of the myocardial ischemia, a significant tropi rise may be indicative of acute myocarditis in the appropriate context. And we'll see what is happening about the tropi later on after investigation. COVID-19 usually produces myocarditis in two ways. One, by direct cytopathic effect, that is direct injury to the myocardium, and second, by through inducing the situation of cytokine storm. The range of presentation may vary from symptomatic state to mild dyspnea and fatigue to intractable heart failure with cardiogenic shock. So myocarditis is a strong possibility here if we consider all along from the history to examination findings. In myocarditis, patient may not have any chest discomfort or chest pain. Patient only may present it with features of the heart failure, along with features of the COVID pneumonia, which has been occurring in this patient. The second possibility of the etiology of the heart failure in these cases may be acute coronary syndrome, because you see the patient is hypertensive and she is a smoker. These two cardiovascular risk factor is present in this particular patient. Along with age is also a risk factor for this patient. She is in menopausal age group. So you see the two major cardiovascular risk factors along with a minor cardiovascular risk factor is present here. So increase the how it is common. Is it usually 8 to 10% incidence? COVID-19 pneumonia AMI has been defined as the elevation of the high sensitive cardiac troponin values above 99 percentile of its upper limit of normal, or any evidence of new ECG or echo changes. Acute myocardial infarction in the COVID situation may occur due to plaque ulceration, rupture with thrombosis, which we used to call it type 1 myocardial infarction, or due to supply-demand mismatch, type 1 myocardial infarction, which may occur in the setting of the cardiogenic shock, respiratory failure, and also hypoxemia. Now, one thing is very important is the pretest probability. For diagnosis of any cardiovascular disease, particularly ischemic setting or atherosclerotic cardiovascular disease, the pretest probability usually plays a vital role for diagnosis. So it should be based on ECG signs, age, sex, previous history of the myocardial infarction, presence of other cardiovascular risk factors. In this particular patient, there is no chest pain, suggestive of ischemic heart disease, which I have already told, and there is accumulation of the cardiovascular risk factors are not so much, and this patient is not diabetic, not dyslipidemic, there is no family history of coronary artery disease. So only hypertension, the smoking, and the menopausal age is the three aggregation of the three cardiovascular risk factors in there. So probability of acute coronary syndrome is unusual in this particular case. If we consider the septicemia, septicemia is a life-threatening organ dysfunction caused by dysregulated host response to the infection. COVID-19 can cause sepsis and multi-organ failure leading to death. So only the viral infection and its multiplication can produce multi-organ failure and death. Direct viral infection or the presence of a bacterial or viral co-infection may predispose to the condition. 80% of the patient's specimen culture does not show any bacteria or fungus, so the viral infection may be the only reason for the sepsis. Although she has fast breathing, she has fast heart rate, she has high fever, but there is no chill rigor, patient has got normal sensorium, there is no alteration of the sensorium, there is no skin rash in the form of petechiae purpura, there is no history of reduction of the urinary output. The septicemia may be a remote possibility. What is about the acute pulmonary embolism? This is one of the underdiagnosed serious medical problem, and this issue has been raised again in the background of the COVID-19 pneumonia, because the patient with COVID-19 pneumonia, due to various reasons, there is a prothrombotic stage. Along with there is de novo formation of thrombus within the pulmonary circulation, particularly in the microvascular channels. The incidence is about 13 to 23% among the hospitalized patients. The local immune thrombosis triggered by the viral infection and the classic venous thromboembolism caused by severe prothrombotic state and the transient provoking risk factors may be responsible. In this particular case, there is no symptoms suggestive of acute pulmonary embolism because the patient has got no severe central chest pain. In acute pulmonary embolism, when there is acute right ventricular strain due to right ventricular ischemia, patient may develop as ischemic chest pain as it occurs in acute coronary syndrome. At the same time, as the right side of the heart is affected, right ventricle, right atrium, and the right side of the circulation is affected, so there will be some change in the jugular venous pressure, you see, as well as the wave pattern. So here in this particular patient, there is no jugular venous pressure changes or any wave changes. And the absence of any precordial findings virtually exclude the possibility of acute pulmonary embolism. The precordial findings of the acute pulmonary embolism, you see, there may be presence of tricuspid regurgitation, there is presence of pulmonary regurgitation, and if you consider the heart sound, there may be presence of right ventricular third heart sound. In this case, there is left ventricular third heart sound along with gallop rhythm. So that may produce some confusion with left ventricular failure event. So acute pulmonary embolism, although a very common occurrence, you see the 13 to 23% in the hospitalized patient. Even then, some studies shows that even 40% of the hospitalized patient may have some episodes of acute pulmonary embolism. So although there is common occurrence, but considering all the clinical profiles, history, and the examination findings, it does not completely fit with the acute pulmonary embolism. So lastly, the one of the devastating and the life-threatening with a high mortality rate that may happen in a patient suffering from COVID-19 pneumonia is the cytokine storm syndrome. It is as like as a storm. When the human system is not able to counteract the virus and to conclude the inflammatory response with aberrant production of the cytokines that lead to macrophage hyperactivity, resulting in the destruction of multiple organs, and the death occurs in about 5 to 10% of the COVID patient about 7 to 10 days after the onset of the symptoms. Our patient presented at the 8th day of the symptoms. You see, it may be compatible with this diagnosis. Hyperactive, dysregulated, overwhelmed immune response against SARS-CoV-19 virus. This is the situation here, and the immune response cannot differentiate self from non-self. It is one of the vital function of the immune system to differentiate self from the non-self, and the cytokine released from the cell communicate with the other cells to jointly combat its enemy. But in this particular case, this overwhelming immune response sometimes produces failure of the differentiation between self from non-self. That may result in killing of the virus, no doubt, as well as killing of the virus infected cells, along with which are we concerned, and most dangerous one is it kills the normal cell as well as tissues of our body like heart, which are the vital organ of our body, heart, lungs, liver, kidney, etc., ended up with multi-organ failure, which can be recognized by the exacerbation of the symptoms which has been occurred in this patient, reappearance of the fever and the general deterioration of the general condition. And with the help of the certain investigations parameters, I am not telling it now. So this cytokine storm, which I've already told that the cytokine storm ultimately leads to development of acute acute respiratory distress syndrome with development of multi-organ failure. The inflammatory signals produces dendritic cells, monocytes, macrophages to produce abundant amount of cytokines, and these abundant cytokines fails to function it's properly with failure of differentiation between self non-self, ultimately leading to destruction of the organs. So if we consider all the differential diagnosis, then what should be the most appropriate clinical diagnosis in this particular case? If we see all along from symptoms to signs, then I think it is the myocarditis with heart failure along with moderate COVID-19 pneumonia and systemic hypertension should be the complete diagnosis in this particular case. If anybody differs from me, he or she can raise hand or she can told his diagnosis. May I take some time to get the response from the participants? So nobody is interested to participate here. So let us go for investigations. What investigations we want to do? I think in the last few lectures or last few discussion with some case scenarios, everybody goes through the investigations which are necessary for diagnosis of the COVID-19 pneumonia and which are essential for assessment of the patient, and sometimes for prognostication of the patient we have to do some investigations, and to identify the complications we have to do some investigations. So for diagnosis purpose, for diagnosis of the COVID, we have already know that the patient underwent RT-PCR COVID in the Rajshahi and that was positive. So we don't think that further investigations are necessary for diagnosis of the COVID pneumonia. Rather, we have to focus on the diagnosis for the heart failure, either she is suffering from heart failure or not, and what should be the etiology of this heart failure in this particular patient. Either it is the myocarditis, either acute coronary syndrome, either it is systemic hypertension, either it is a cytokine storm syndrome, or either all the things combined together leads to such a complex scenario that leads to the patient for development of the acute heart failure. So we have to investigate line by line. First, the simple parameter in a patient with COVID pneumonia is complete blood count. Even a patient suffers from acute heart failure or chronic heart failure, complete blood count or complete blood picture should be an initial investigation to choose, because it can tell many things for the patient. It helps in diagnosis, it helps in identification of the problems or the precipitating factors that leads to development of the heart failure. So how CBC can help? If the hemoglobin percentage is low, it can precipitate heart failure. If the hemoglobin percentage come down drastically from its basal value of the patient at the time of the presentation, then it indicates in the COVID situation a worsening situation. So less hemoglobin in a patient with COVID should arouse the suspicion of development of cytokine storm syndrome. Why the hemoglobin may be reduced in COVID situation? There is decreased proliferation of the erythropoietin progenitor cells. There is reduced stimulation of the erythropoietin and increased half-life of the erythrocytes. How the total leukocyte helps? Total leukocyte count may help in many ways. In a patient with COVID-19 pneumonia, absolute neutrophil count may be increased, absolute lymphocyte count usually decreased. So these two scenarios may combine together, ultimately leading to a situation which we call it neutrophil leukocyte ratio alteration. So usually it is 1 to 3, and in COVID situation, particularly those patients who are in grave condition, who has got a poor prognosis, usually the NLR ratio raised from 4, 5, 6, 7, even 8 up to that limit because of several reasons, which we'll try to discuss later on. Lymphocyte macrocyte ratio also increases. Absolute platelet count decreases due to consumption in microthromboembolic manifestation. Platelet lymphocyte ratio also may be reduced. The precise mechanism of these blood cell changes is unknown. In hemopoietic system, in general, we don't know how these cells are decreasing, some are increasing. Reduced production, augmented destruction, and the augmented consumption are considered to be the appropriate etiology. Decrease in lymphocyte counts is more than the decrease in the platelet count. So next is CRP. Although we are discussing about the heart failure, but CRP can predict those patients who are going to develop myocardial injury and who are going to develop heart failure and who are going to develop a poor prognosis in the form of heart failure, in the form of the cardiogenic shock. I think it has been discussed previously. I want to skip it here. Serum ferritin, I think it has also been discussed. High ferritin level is usually associated with cytokine storm. It is one of the inflammatory marker as well, and sometimes it participates in the development of cytokine storm syndrome. And serum D-dimer, you have already all knows about that, and you are working in the COVID situation in a COVID ward, so you better know than me. Now we have to give attention on the cardiac stress biomarker, number 1, and cardiac injury biomarker. What is cardiac stress biomarker? There are biomarkers which are elevated in certain cardiac condition. Some are biomarker of the stress, some are biomarker of fibrosis, and some are biomarkers of the necrosis. The NT-proBNP is a hormone which is secreted by the cardiomyocyte in the ventricles in response to stress caused by the increased blood volume. So increased blood volume that will stress the ventricles, particularly left ventricle, and to some extent left atrium. Small amount of the cardiac stress biomarker, that is proBNP and NT-proBNP, is always produced and is released into the circulation. It should be measured when we suspect heart failure, because it is not a routine to do NT-proBNP in all the patients presenting with COVID-19 pneumonia. When you feel doubt that the patient has got some components of the heart failure, then you have to do that. It helps in assessment of the effect of the therapy, as well as the NT-proBNP can predict the outcomes in the heart failure. How it predicts? With treatment, if it reduces, and at the time of presentation, very high rise of the NT-proBNP predicts the poor outcome. And in response to treatment, if the NT-proBNP is getting down, then you think about the patient is improving well with your treatment, responding well. The patient with COVID-19 often demonstrates significant elevation of the BNP or NT-proBNP, but the significance of these findings is uncertain. Should not necessarily trigger an evaluation or treatment for heart failure unless there is clear evidence for the diagnosis. এখানে এই জিনিসটা is very important. NT-proBNP অথবা proBNP বাড়লে হার্ট ফেলিওর হয়ে যাবে কোভিড সিচুয়েশনে, তা নয়। একটা হচ্ছে যে in the absence of any stretching over the left ventricle or left atrium in a patient with COVID-19 pneumonia, patient may have raised BNP NT-proBNP level. The virus itself may elevate the NT-proBNP, but the level in COVID patient may by binding with the ACE or by producing cardiac injury. So by producing cardiac injury, by binding with the ACE, internalization in the cells, by producing necrosis of the myocardial cells, it may produce raised troponin level. NT-proBNP might be an independent risk factor for in-hospital death in patients with severe COVID. So, as like as CRP, as like as neutrophil leukocyte ratio, as like as ferritin, this high level of NT-proBNP can also predict the increase in hospital mortality in patients with COVID-19 pneumonia. So you see the normal level. I don't go in details with these values in the investigation panel. Serum troponin values. This is a cardiac injury biomarker. You all know in response to any necrosis of the myocardial cells, there is release of the certain cardiac structure, release of the certain cardiac enzymes. You know the creatine kinase, CKMB. You know the name of the cardiac troponins, T and troponin I. In our country, it is the troponin I which is more practiced for diagnosis of any cardiac injury. In the situation of the COVID-19, it helps in the rapid diagnosis, prognostication, as well as treatment of the myocardial infarction, and also aid in the diagnosis of even microinfarction, particularly with the help of the high-sensitive troponin I. Incidence of the cardiac injury, in hospitalized COVID-19 patient is 8 to 24%. So it's a huge percentage of the patient may succumb cardiac injury from the COVID toxic effects. And the mortality rate in a patient with COVID-19 patient who has succumbed the cardiac injury is about 30 to 70%. So how the cardiac biomarkers may be elevated with the COVID-19 by producing cytokine storm leading to coronary artery luminal ulceration, leading to plaque rupture, thrombosis, and type 1 myocardial infarction. Second, by producing respiratory failure, by producing shock, by producing hypoxemia, there is induction of the situation of supply-demand mismatch, leading to type 2 respiratory failure. And third one is direct myocardial injury by the viral infiltration. The mild elevation of the cardiac troponin I concentration less than 2 to 3 times upper limit normal is particularly in elderly patient with pre-existing cardiac disease do not require any workup or treatment of AMI unless there is strong suspicion of acute coronary syndrome or an ECG change. It indicates acute myocardial injury related to COVID-19. So when the elevation of the cardiac troponin is more than 2 to 3 times than normal, then we have to work up for finding the etiology. You see how the cardiac troponin, what are the situations where cardiac troponin may be raised in those situations. You see the sepsis, hypoxemia, inflammation itself, stress-induced cardiomyopathy and myocarditis all may lead to raised cardiac troponin value. So procalcitonin, you have already go through the topics of procalcitonin. I am not getting it in more detail, but one thing is important. The raised procalcitonin may be an indicator of the disease severity on the COVID-19 patient and may contribute to determining the severity of the patient infected with SARS-CoV-2. Moreover, the serial PCT or procalcitonin measurement may be useful in predicting the prognosis. The higher procalcitonin values also indicates bacterial co-infection. So when there is raised procalcitonin, it indicates two. We have to alert about the bacterial co-infection, and we have to have doubt over the bacterial co-infection. At the same time, we have to alert about the patient probably is going to a state of poor prognosis. So now they come to the for diagnosis of the cardiac condition. ECG, you know, the one of the important parameter which is very much available now even in the union level as well, beginning from Dhaka city to even union level, the ECG is available. But problem is the interpretation of the ECG sometimes may produce confusion about the diagnosis. But what ECG changes may happen in a patient suffering from COVID-19 pneumonia? How COVID virus may produce some ECG changes? What type of ECG changes may be produced by the COVID virus? You know, when it produces acute coronary syndrome, you will find the changes in the STT wave, you will find the change in the Q wave, you will find in the change of the conduction disturbances, you will find the change in classical form, in the form of the ST elevation MI that conforms to the arterial territory of the coronary arterial system. And as well as it may produce some arrhythmias. So beginning from mere sinus tachycardia to classical ST elevation myocardial infarction may happen in COVID-19 pneumonia. One thing is very important to differentiate from myocarditis to acute coronary syndrome induced ST elevation. It usually in myocarditis, it is the inferolateral area where it shows the ST elevation, and the degree of the ST elevation is minimal, around 1 millimeter or less, like that. But when there is acute coronary syndrome in the form of the type 1 myocardial infarction, there will be classic elevation, more than 2 millimeter elevation of the ST segment, cove pattern in the leads that has been affected by the block arterial territory, either LED system or LCX or RCA. And arrhythmia may happen in both the situation, including myocarditis to pericarditis or even in acute myocardial infarction also. So these are the few ECGs you see. This is the ECG where the number one ECG shows the patient has got left bundle branch block with sinus tachycardia. Left bundle branch block may be a consequence of the acute myocardial infarction due to development of the complication affecting the left bundle, or the left bundle branch block may be a manifestation of the acute ST segment myocardial infarction. If the patient has symptoms that is very classical for myocardial infarction and they presented for the first time with left bundle branch block, then you have to strong doubt about the patient probably has acute myocardial infarction. And in the second ECG, you see there is scope pattern of ST elevation affecting beginning from V4, V5, and to some extent V6 and 1 AVL. That leads to doubt about the lesion probably in the left anterior descending artery, because these are the anteroseptal leads and also the lateral leads. 1 AVL is lateral leads, and you see the V3, V4, V5, these are the anteroseptal leads. So the patient has got extensive anterior ST elevation myocardial infarction. So this type of ECG changes may happen in a patient with COVID-19 pneumonia. So echo. One thing is important, do not perform routine cardiac imaging in a patient with suspected or confirmed COVID-19. Perform echo in patient with suspected or confirmed COVID-19 only if the management is likely to be impacted by the imaging results. Focused cardiac ultrasound study and critical care echocardiography performed at the bedside are effective options to screen for cardiovascular complications of the COVID-19 infection. Previously, when we see some ECG changes, we want to do the echocardiography for further assessment, about the diagnosis, to assess any of the complications, to assess the ejection fraction. But in the COVID situation, these are not advocated, because there is high risk of transmission to the healthcare workers as well as surrounding people. So it is not advocated. Only it is advocated when you think about the echo may change the diagnosis and echo may change the treatment strategy and the outcome of this patient. Otherwise, for only diagnosis, for only supportive evidence, you need not to do an echocardiography. But echocardiography, when it is done, it may show many things: diffuse hypokinesia, or a focal hypokinesia or akinesia or dyskinesia of some segments corresponding to the arterial territory of the coronary arteries, will give strong doubt about the coronary events. Chest X-ray, although a very a good practice from the previous days, chest X-ray can tell many things. In this particular COVID patient, the chest X-ray will help you to diagnose a COVID-19 pneumonic consolidation in particular patient, as well as it may show the features of the cardiogenic pulmonary edema. It may show the features of the non-cardiogenic pulmonary edema, that is adult respiratory distress syndrome, and at the same time, some idea will be given by the cardiac shadow in this patient. If the cardiac shadow is enlarged in transverse diameter concomitantly, there may be doubt the patient may have pre-existing any cardiac problem. So you see the classical bat swing appearance of the cardiac B-line, appearance of the bilateral pleural effusion, appearance of the prominence of the upper lobe vessels may indicate the patient has got features of the acute pulmonary edema. Here you see some X-rays. In the first X-ray, you see the patient has got perihilar haziness, and the second X-ray, same thing. And with treatment, the patient on the third X-ray, you see the edema fluid on the perihilar region disappears, and the cardiac shadow, a bit compared to the first film, the cardiac shadow has been reduced. So with treatment, the edema fluid disappears, and to some extent, the cardiac shadow getting its previous size. These are the features of some COVID pneumonia, which we call is ground glass opacity, peripheral, bilateral, basal, subpleural, and so on. So these are the features of the COVID pneumonia. You see in this second X-ray, there are features of the acute respiratory distress syndrome. There is non-cardiogenic pulmonary edema, and the opacity is usually distributed most peripheral part of the lung fields, sparing the perihilar region. CT scan helps in basically diagnosis of the COVID-19 pneumonia and its categorization and its severity assessment. I will not go in details in this particular investigations. You know all the things by sometimes. And we used to assess the patient by scoring the severity depending on the how percentage of the lung parenchyma has been involved by the COVID patient. Score 1, 2, 3, 4, and 5. So all the investigations majority of the investigation has been done in our patient, and you see the investigation profile of our patient. She has neutrophilic leukocytosis with lymphopenia, raised CRP value, raised HGPT, raised serum creatinine, normal sodium, potassium, and other electrolytes, chloride and bicarbonate. Serum ferritin is about 4 times raised, 4 to 6 times raised. Serum D-dimer raised about more than 3 times. NT-proBNP raised. Tropoid 2 times elevated than normal. And the ECG shows sinus tachycardia, but there is no ST deviation, no bundle branch block. Echo was available in the CCU in Dhaka Medical College event. So it has been done on the bedside, which shows mild global hypokinesia, normal cavity dimensions, and the wall thickness with ejection fraction of 42%. Chest X-ray shows bilateral peripheral basal infiltrate with perihilar haziness. HRCT shows 30 to 35% involvement of the lungs. So with the case scenario and with this investigation profile findings, now what should be our final diagnosis in this case? I like to invite the participants to talk about, to tell about the confirmed, what should be the confirmed diagnosis. Because when we discuss the matter on the differential diagnosis, we have strong doubt about 2 things. One is myocarditis with heart failure, along with COVID-19 pneumonia and the hypertension, along with the diagnosis. And second was we have features that was most likely compatible with the cytokine storm syndrome, leading to myocarditis, heart failure, and so on. So with all this investigation profile, where we should stand for? Or do you think we have to need other investigations to reach a conclusive diagnosis? What is your opinion?
আপনারা একটু রেসপন্স করেন, আনমিউট করে করতে পারেন অথবা চ্যাট বক্সেও লিখতে পারেন। Investigation profile.
The female was hypertensive, she was smoker, and at the day of presentation she has got saturation 91%, and she has got the features of the acute left ventricular failure, and at the day of presentation she has blood pressure 180 by 90 millimeter of mercury. She has no ZVP change, she has no ankle edema, and she has no hepatomegaly. Lungs reveals that she has got bilateral basal crepitation, along with some crepitation extending up to the apex of the lung field. And you see the investigation where there is evidence of the liver injury, evidence of the cardiac injury, and evidence of the renal injury, along with high rise of CRP, serum ferritin, serum D-dimer, and NT-proBNP, and some ECG change with some echo change. So all these findings, if we correlate all the investigations findings with her clinical profile, then I think what we have suspected earlier, the two diagnoses should be matched.
একজন রেসপন্স করেছে, ডক্টর সারা রেসপন্স করেছে, moderate COVID pneumonia with hypertension, with heart failure, with reduced ejection fraction due to myocarditis, mostly due to cytokine storm syndrome.
Very nice, very good. I think she was very much attentive from the very beginning, and she gave an excellent input here. If anybody differs or anybody wants to do other investigation to find out a conclusive diagnosis, she can tell. Yes, who is the Dr. Shara has told that the myocarditis is a possibility because tropi has been elevated, but it is not so much. It is only 2 times elevated than normal, and the ECG has got no elevation in the form of acute coronary syndrome like acute myocardial infarction. Only there is sinus tachycardia, and the echo does not show any focal or local hypokinesia compatible with any of the myocardial territory supplied by the coronary artery. So she has got very strong evidence of the myocarditis, very good. And she has got the features of the heart failure, clinical as well as on the chest X-rays. And what other things told? He has got evidence of the multi-organ involvement as well. So she has cytokine storm syndrome. But is it the tropi, ECG change, and echo, is it sufficient enough to give a conclusive diagnosis of the myocarditis, or you need more thing to do? Any other sophisticated investigation you need to do? So yes, anybody can raise the questions of doing of cardiac MRI, because that will give a that will give a very insight about the occurrence of the myocarditis, because sometimes myocarditis may be so occult, maybe so much focal, that by echo or by ECG change you cannot give a conclusive diagnosis. So in those cases, cardiac MRI may give a conclusive diagnosis for you about the occurrence of the myocarditis in any situation. So cardiac MRI, it is not available, it is not so much available in Bangladesh or even in Western world. So cardiac MRI you cannot do whenever you want, you cannot find it at your hand. So you have to wait and you have to do the investigations after thinking many things about the situation. So cardiac MRI, although a very attracting investigations for diagnosis, but for all the COVID patient, you will not get it at hand. So I think cardiac MRI should not be a proper investigation to suggest at this level. Second, coronary angiogram. Yes, it is available investigations, and many cath lab centers are here in Dhaka as well as outside the Dhaka. So you can do that, but in this COVID situation with all these investigations, symptoms, degree of tropi raise, and the echo findings does not give any doubt about the acute coronary events. So I think coronary angiogram will not be appropriate in this particular case. And somebody may raise the questions of doing endomyocardial biopsy, but I think that is not also essential for diagnosis of myocarditis. So these two investigations, although is very appealing, but it is not indicated in this particular case, and I think it is not available in majority of the centers in our Bangladesh, even in Dhaka. So I think these are not essential for diagnosis or even for assessment. So with all above investigations, we can conclude about our case that it may be a case of cytokine storm syndrome with myocarditis, with heart failure, with liver and renal involvement, definitely with hypertension, with COVID-19 pneumonia moderate. So I think the Dr. Shara has excellently chalk out the situation. So thanks all the participants from me that you have attended the today's discussion, today's case scenarios very attentively. So thank you all the audience for giving so a nice concrete diagnosis for this patient. So how we'll manage this patient? This is a very fundamental thing. We can come to a diagnosis, but how should we treat the patient? You know, the symptomatic and supportive treatment should be there for the COVID patient. You know, for fever, you have to treat the patient with paracetamol. For pain, you have to treat the patient with paracetamol. A good nutrition, good vitamin support, vitamin D, zinc, it helps in development of the immunity of the patient. So this symptomatic and supportive treatment is there. Along with COVID-19 patient, always respiratory support should be a separate entity to describe all the management schedule, because the respiratory problem is the main presenting features of the COVID-19 pneumonia. I think it has been discussed in many forums from the beginning, from oxygen administration by the nasal cannula to high flow nasal cannula to non-invasive pressure ventilation to invasive ventilation. You know all the things and how it should be done. And what our concern is treatment for the hypertension, treatment of the myocarditis, and for treatment of the heart failure. At the same time, you have to manage the cytokine storm, which has created so a devastating situation. So let us see how we can treat the patient. Now, when you treat a patient with heart failure, you have to see all the things. Either the patient has got any precipitating factors, either the patient has got any arrhythmia, either the patient has got thyrotoxicosis, either the patient has got fever, either the patient has got pulmonary thromboembolism, either the patient has got any sorts of tachyarrhythmias or bradyarrhythmias. You have to treat all the things along with management of the heart failure. So let us see what comes here. We have to address the cytokine storm, which in this particular case, we think about the main problem to produce multiple organ injury leading to this grave situation. So you think to treat the patient with cytokine storm, we have many things at our hand at the moment. Number one is corticosteroid. It shows a very promising result in different studies. So it's one option. Number two options are IL-6 inhibitors in the form of tocilizumab, IL-6R inhibitor in the form of sarilumab. In our country, tocilizumab is available. And JAK inhibitors, it is also available in our country, baricitinib or tofacitinib. So these two drugs are available here along with corticosteroid all the time. So along with some other drugs in the form of IL-1 blocker, anakinra. So these are the few drugs, but in our country it is available corticosteroid, tocilizumab, and the JAK inhibitors, baricitinib, even tofacitinib. But the studies are in favor of baricitinib, but it should be always administered along with our intravenous antiviral drugs. And colchicine is considered to be an anti-inflammatory drugs, and in this situation, it may help to some extent by reducing the inflammatory phenomena. So corticosteroid, tocilizumab, and the baricitinib, these three drugs you have got available at your hand to combat the situation of the cytokine storm. And how will treat the myocarditis in this situation? No doubt, supportive care. Supportive care means if the patient has got hypotension, you have to support the blood pressure by administration of the inotropes. If the patient has got different from arrhythmia, you have to treat these arrhythmias. At the same time, you have to consider immunomodulation, either in the form of corticosteroid or IL-6 inhibitor. So when the patient has got evidence of myocarditis, so you have to modulate the immune system with corticosteroid or IL-6 inhibitors. And how we treat the hypertension and heart failure, and these are basic principles of treatment. You see, when the patient comes with features of the heart failure along with the features of acute pulmonary edema, then intravenous loop diuretics a very effective drug. Those doctors, junior doctors who are working in the CCU or who has the experience of treating a patient with acute left ventricular failure in your medicine ward, then you see this is the only drug which upon administration patient get relief immediately by different mechanism. We know this is the very name suggests the diuretics means it produces diuresis, increased urine formation, fluid loss from the body, so the pulmonary edema resolves or improves. But this is the scenario when where the drugs get a time of 2 to 4 hours, it can induce diuresis. But immediately after the administration of the drugs, there is development of venous dilatation immediately. So the patient, by venous dilatation, there is reduction of the preload. So patient gets very much comfort as soon as you give the intravenous diuretics. So intravenous diuretics you can give in the form of continuous controlled intravenous infusion or intermittent bolus or combined. So all the things are effective. In different studies, it has been shown that the continuous intravenous infusion get a superiority in terms of symptomatic relief of the patient, in terms of diuresis, more diuresis. The continuous intravenous infusion is better than the intermittent bolus. And second thing is intravenous nitrates. Definitely it should be controlled continuous intravenous infusion, because the nitrate is a drug which can produces profound vasodilatation as well as arterial dilatation. So you can reduce the preload as well as afterload at the same time. And this is a drug which has got a very short half-life. Once you see the improvement, once you see the hemodynamics or falling blood pressure, you can stop the drugs, you can reduce the infusion, and so the patient with hypotension will improve. So these drugs can act in acute pulmonary edema very dramatically. At the same time, in our situation where the patient has got hypertension as well as heart failure, this is a very magic drug which can produce effect like a double sword, a double-edged sword. That is, at the same time, it will reduce the blood pressure, it will reduce the edema fluid as well. Intravenous sodium nitroprusside, when the patient has got hypertension as well as heart failure, then sodium nitroprusside is a very good drug. It produces arterial as well as venous dilatation, reducing both preload and afterload, and as well as control of the hypertension. What is about the intravenous opiates? These drugs, the name of these drugs is now we are going to forget, because these are not very much used, commonly used drug. But when we were students or when we passed in about 5 to 10 years back, this is a very commonly used drug. And you see the opiates, when you administer the opiates, the patient improved tremendously after administration of these opiates, particularly the morphine, not the pethidine. Symptoms. Number one, morphine can reduce the anxiety, because one of the clinical manifestations of the problem is anxiety, and the patient looks very apprehended. So when you give the morphine, it will allay, it will reduce the anxiety, it will produce comfort to the patient. And at the same time, morphine produces a good venodilatation. which is required during the development of the acute heart failure. Venodilatation reduces the preload, and the patient, by reducing the preload, the heart can cope with the problem. He will get time, he will improve his contractile ability. So intravenous opioids, number one, by reducing the anxiety. Number two, by reducing the preload by producing venodilatation. And thirdly, the opiates is considered to be sympatholytic. So by reducing the sympathetic overactivation, vasoconstriction, and by reducing the preload, the opiates can act dramatically in the situation of the left ventricular failure. And whether in this particular situation, where the patient has got COVID-19 pneumonia and hypoxemia, should we going to give the intravenous opiates, considering all the situation? I think this is not a situation to give the opiates as the patient has got hypoxemia. One of the danger of the intravenous opiates is development of apnea. Immediately after administration of the patient may develop respiratory arrest. So when you give the opiates, you have to prepare with all the things for intubation. So I think in this particular situation scenario, intravenous opiates is not a drug of choice. And the drugs which are named as ACEI or ARB or ARNI, these are the drugs which has got a dramatic impact on the not only for symptomatic relief, but also for improve the survival of the patient. And lastly, the beta blocker, carbidiol, bisoprolol, and metoprolol. So I think these intravenous diuretics, intravenous nitrates, ACE inhibitor, ARB, and ARNI, anyone, and the beta blockers, all the things are necessary for management of the heart failure in a patient with hypertension. So these management protocol or management schedule or management plan is as like as a patient suffering from acute heart failure from any situation other than COVID-19 pneumonia even. But in this particular case, we are not choosing the intravenous opiates. In other situation, in the absence of any bronchial asthma or COPD, along with intravenous opiates, other drugs may be preferred. So how will follow up the patient? Regularly, you have to ask about the symptoms, see the pulse, whether it is reducing or not, see the blood pressure, measure the blood pressure, measure the saturation, auscultate the lungs, auscultate the precordium. And if you want to biochemically see something, it is the NT-proBNP. If it is reducing gradually, then you see there is improvement of the situation. If you do the serial X-rays, you will see that there is disappearance of the edema fluid in the perihilar region, which I have shown earlier in X-ray. So during discharge, you should have to add ACE inhibitor, beta blocker, diuretics, and ultimately you have to add a mineral receptor antagonist. And if with this medication patient improves oil, then you continue the medication, follow up the patient by doing clinical exam, by doing serial NT-proBNP, by doing echocardiography. If the patient does not improve with all this medication, you have to think about treatment for advanced heart failure management. These are the 2021 management protocol or heart failure with reduced ejection fraction recommended by ACC-AHA. We will not go in details, and which at the end of the treatment, which we want to tell, in the chronic stabilized form of the heart failure, there are four pillars of the heart failure. One is ARNI, angiotensin receptor blocker, and the neprilysin inhibitors, beta blockers, MRA or mineral receptor antagonist, and you will see the name of SGL2 inhibitor, which were introduced into the market as an anti-diabetic agent, now is recommended as an anti-failure treatment in a patient with heart failure. There are situations where ACE inhibitor ARB initially was not advocated in a patient suffering from COVID pneumonia due to fear of aggravation of the clinical scenario of myocarditis or heart failure or myocardial damage. But now it is thought that it is it is not contraindicated. Rather, its use can lessen the severity of the development of myocarditis or myocardial damage. So in COVID-19 status, if the patient is COVID-19 positive and the patient has got specific indication for LV dysfunction like LV dysfunction, CKD or power stroke, so you can start the ACE inhibitor ARB without any confusion. And if the patient even negative, but the patient is at risk of acquiring the COVID-19 pneumonia, then even you can start ACE inhibitor ARB. So ACE inhibitor and ARB, rather, there is no contraindication. You can start, you can continue, you can adjust the dose of this inhibitor or ARB in the context of hypertension or any patient with heart failure. Rather, now some studies have shown that the ARB has got some protective effect against the myocardial damage induced by COVID-19.
একটা ইম্পর্টেন্ট জিনিস আমি কোশ্চেন করি, যদি অনুমতি পাওয়া যায়।
স্যার, শিওর।
সেটা হলো যে হার্ট ফেলিয়ার পেশেন্ট গুলায় আমি যে সাধারণত আমরা মার্কার হিসাবে প্রোবিএনপি বা অ্যান্টি প্রোবিএনপি ইউজ করছি, কোভিড-19 এর সময় এটার কি কোনো ব্যত্যয় হয়? সেক্ষেত্রে কি শুধু কোভিড-19 এর জন্য, কার্ডিয়াইটিসের জন্য কি প্রোবিএনপি বাড়তে পারে? না, যখন এটা বাড়বে তখন বুঝতে হবে যে না, হার্ট ফেলিওর কোএক্সিস্ট করছে কোনটা যদি বাড়ে। আমি সেক্ষেত্রে এইজের কি ইফেক্ট আছে, যে আমরা একটা কোভিড পেশেন্টের আমি প্রোবিএনপি করলাম, এখন এটা কি শুধু কোভিড এর জন্য কি প্রোবিএনপি বাড়তে পারে, নাকি প্রোবিএনপি বাড়লে পরে আমাকে বুঝতে হবে যে এটা হার্ট ফেলিওর কোএক্সিস্ট করছে, either due to carditis or due to acute coronary syndrome related to COVID? কোনটা মনে করব আমরা? 2 নম্বর কোশ্চেন হলো এইজের সাথে কি সম্পর্ক আছে? সব বয়সে পেশেন্টের জন্য কি আমরা একই রকম ভাবে বিবেচনা করব?
প্রথম হচ্ছে COVID-19 virus itself may produce some rise of the anti-BNP or pro-BNP along with tropoid levels. So merely rise of the anti-pro-BNP does not indicate the presence of the heart failure. It can give some clue or give some doubt. Clinical context is very important for consideration of the clinical context. So merely presence of raised tropoid value does not indicate the presence of the heart failure. Even with a COVID-19 pneumonia with cardiac injury, patient may have elevation of the anti-BNP or pro-BNP. And regarding the age, more is the threshold value for diagnosis of the heart failure or the level of the anti-pro-BNP. So a young man may have with same level of anti-pro-BNP, elderly person same level of pro-BNP, and the young man with same level of pro-BNP is not the same, because of the diastolic dysfunction, the stiffness of the myocardium, left ventricle. The elderly person may have some form of elevation of the anti-pro-BNP, even at resting condition. So elderly age for diagnosis, the threshold value for anti-pro-BNP more. I have shown it in my one slide that more than 70 years age group, the threshold for diagnosis for heart failure with anti-pro-BNP may raise to even 1500 microgram per ml, nanogram per ml.
একটা কোশ্চেন এসছে স্যার আমাদের, হাউ অ্যাবাউট দ্য ম্যানেজমেন্ট অ্যান্ড ফলো আপ ইন কেস অফ পেশেন্ট উইথ পোস্ট কোভিড উইথ হার্ট ফেলিওর, হাউ পেশেন্টস ডিটোরিয়েশন ডিউরিং পোস্ট কোভিড পিরিয়ড? Post COVID with heart failure, in case of patient with post COVID with heart failure.
Post COVID with heart failure, if number one, it basically depends on the degree of involvement or degree of the necrosis of the myocardium induced by the virus at the time of the presentation. If the patient has got fulminant myocarditis, that is, there is massive necrosis of the myocardium and the patient has developed reduction of the ejection fraction much lower, and there is increment of the left ventricular dimension, then this patient does not behave very goodly, or this in response of the treatment is not so good. So the necrosis is massive, then in post-COVID situation, management may be difficult one. But if the damage is smaller one, little one, and there is occult or focal necrosis of the myocardium, which does not impact the myocardial performance much, this patient usually improves better. In post-COVID situation, you have to manage the patient properly. If the management is proper one, and patient has got concomitant, does not have any concomitant other cardiovascular risks in the form of like chronic kidney disease, any chronic respiratory problem, any other cerebrovascular disease. Usually these sorts of patients with conventional treatment of heart failure improve very much. একটা কোশ্চেন দেখা যাচ্ছে যে ডক্টর সারা, a post-COVID patient with heart failure with preserved ejection fraction has any chance to develop acute heart failure after 1 or 2 months after? And basically, there is no mechanism to development of acute heart failure 1 to 2 months later on after recovery from the COVID situation. We don't know any case, or we did not go through any case of such kind of case that the patient has got recovery from the COVID situation, but presented with acute heart failure 2 months later on for COVID. Yes, it may happen if the patient has got other cardiovascular risks and the patient developed some way or rather acute myocardial injury, either in the form of acute coronary syndrome or other, then the patient may present with features of the heart failure. Only for the COVID, he or she recovered from the COVID and later on presented with acute heart failure with COVID-induced cardiac problem. This is unusual, or we did not get such case even in our practical life. And we don't go through like this, such papers as well.
আরেকটা কোশ্চেন ছিল, আমি অবশ্য একটু ডিসকানেক্টেড হয়ে গিয়েছিলাম, স্যার আমি জানি না এটা অ্যান্সার করা হয়েছে কিনা। এ পোস্ট কোভিড পেশেন্ট উইথ হার্ট ফেইলিওর, the ejection fraction has any chance to develop acute heart failure after 1 or 2 months after?
Just I have answered the question just
Okay.
now.
যেহেতু কোভিড পেশেন্ট আমরা এখন খুব ভালো ক্লোজ এক্সামিনেশন করাটা নিরাপদ না, সাসপেক্টেড কোভিড, শ্বাসকষ্ট নিয়ে আসছে, আমি ধরলাম এটা তো সাসপেক্টেড কোভিড, সেক্ষেত্রে আমি বাইরের কি কি জিনিস দেখে বা বেডসাইড কি কি জিনিস টেস্ট বা দেখে আমি সন্দেহ করতে পারি যে এটা কোভিড নিউমোনিয়া, এটা প্রাইমারিলি হার্ট ফেলিওর। এটা কিন্তু সবার আগে আমি যেটা বলবো, প্লিজ টেক দ্য হিস্ট্রি, টেক দ্য ব্যাকগ্রাউন্ড। ও কি জ্বরের পরে এটা শুরু হলো, নাকি এটা তার পরিশ্রম করে হলো, তাকে চেস্ট পেইন হয়েছিল সেটার জন্য হলো? 1 নম্বর হচ্ছে হিস্ট্রি। 2 নম্বর হলো লুক এট দ্য স্যাচুরেশন। একটা হার্ট ফেলিওরের পেশেন্ট ফ্রোজিং পালমোনারি এডিমা না হলে তার স্যাচুরেশন কমে যায় না, কিন্তু কোভিড নিউমোনিয়াতে সেটা না হয় কিন্তু তার স্যাচুরেশন কিন্তু কমার টেন্ডেন্সি। 3 নম্বর হলো লুক এট দ্য পালস রেট। কোভিড পেশেন্টের পালস রেট অত বাড়ে না, হার্ট ফেলিওর পেশেন্টের কিন্তু সাইনাস টেকিকার্ডি ইজ এ কমন রেসপন্স। তার ডিসনির তুলনায় যদি পালস রেট অত বেশি না হয়, এটা কোভিড হওয়ার চান্স বেশি, কিন্তু তার ডিসনিয়া থেকে পালস রেট অনেক বেশি, এটা হার্ট ফেলিওর হওয়ার চান্স বেশি। 4 নম্বর হলো এটা চেস্ট এক্সরে। এই সবকটাই কিন্তু আমি না ধরেও একটু দেখে কিন্তু আমি মোটামুটি কিন্তু করতে পারছি, এবং যদি ফ্যাসিলিটি থাকে সেক্ষেত্রে হলো গিয়ে ট্রপা এবং প্রোবিট, এই দুটা।
স্যার আমি একটু খালেকুজ্জামান স্যারকে বলবো যে স্যার একটু কি মেসেজ আজকে যদি একটু সামারাইজ করেন স্যার, অল্প একেবারে শর্ট করে, কি মেসেজ আমাদের পার্টিসিপেন্টদের জন্য?
Before the diagnosis of acute heart failure, we have to consider the clinical context of the patient. Is there any pre-existing cardiac problem associated with COVID or not? Because many patients are there who are suffering from pre-existing cardiac problem, develop COVID and deteriorates the clinical situation. So the pre-existing cardiac problem should be should be sought about from every patient. Number 1. Number 2 is what the sir said. From the distance, we have to come to a clinical diagnosis. So either the patient has got COVID-19 pneumonia or a heart failure. In a patient with COVID-19 pneumonia, there are many causes of shortness of breath and the hypoxemia, beginning from itself COVID pneumonia to ARDS to cytokine storm syndrome. So the clinical diagnosis, clinical doubt should be there. And thirdly, only simple 2 or 3 investigation, NT-proBNP, TROP-I, and a chest X-ray. These 3 are sufficient for diagnosis of the patient with heart failure. And lastly, management protocol almost same as other situation. And in these situations, majority of the times you need to administer some intravenous agents in the form of the diuretics, nitrates, vasodilators. So I think in a patient with COVID-19, if the patient has got disproportionate respiratory distress, we have to think about the features. We have to think about the features of the patient is going to develop acute heart failure. That's the last message from me. So thank you organizers, thank you participants for these glorious events of presentation a case scenario in a patient of COVID-19 pneumonia who has cytokine storm syndrome, myocarditis, and the heart failure. And thanks everybody for patience here.
আমার মনে হয় যে আজকে যে আলোচনা যেটা সেটা যদি রেকর্ডিংটা সবাই আবারও শুনে তাহলে কিন্তু অনেক জিনিস তাদের ক্লিয়ার হয়ে যাবে। প্রফেসর খালেকুজ্জামানকে অনেক ধন্যবাদ